Uh, Thanks everyone for joining us tonight for our talk on adolescent mental health. We've got some really interesting speakers lined up, so I'm sure you'll find it really helpful and applicable to our practice. So I might start by introducing tonight's first speaker. Dr. Peter Davies is a child and adolescent psychiatrist with an interest in the assessment and treatment of children, adolescents and young adults. He is able to offer treatment for a broad range of emotional and behavioural difficulties. He provides a comprehensive and thoughtful treatment approach, including individual and family-based psychotherapy, as well as medication where appropriate. Peter studied medicine at the University of Sydney and has trained and worked in psychiatry in a broad range of settings in Australia and in the UK, including the King's College London Institute of Psychiatry and the Children's Hospital. Peter has worked as a consultant psychiatrist in both public and private practice since completing his specialist training in 2012. And we're really thankful for him joining us tonight and looking forward to his presentation. So I'll hand over to you. Thanks, Peter.
Thanks, Kylie. Thank you and thank you everyone for the invitation to speak, to contribute tonight. So as Kylie said, I'm Dr. Peter Davies. I'm a child and adolescent psychiatrist in private practice in Bondi Junction, and tonight I'm going to speak about social anxiety and cyberbullying in the context of adolescent mental health. And that's just a little bit about me. So what I'm hoping you'll get from tonight's presentation is to be able to recognise the key features of social anxiety disorder in children and adolescents, identify appropriate psychological and pharmacological interventions for social anxiety in children and adolescents, and to list some useful steps parents can take if their child is experiencing cyberbullying. And my apologies, just give me a moment while I adjust my screen. Might have to pop out of my presentation for a second, I'm sorry, just while I do that. All right, sorry. Hopefully that's better now. So, so just to start off the conversation, I thought it'd be interesting to start off with this question of, where does shyness end and where does social anxiety begin? Because in some ways they're on a spectrum. They're on a spectrum with each other. I guess shyness, we all know what shyness is. I mean, it's a personality trait, but also an emotional state that, any of us, I'm sure we've all felt to some degree at one time or another. But there are some people who have a much greater vulnerability to anxiety just in their personality structure, who experience these feelings more frequently. Shyness, of course, is feelings of awkwardness or apprehension in unfamiliar situations when interacting with others. Shy people prefer to watch from the sidelines rather than be the centre of attention. But happily, many shy children grow out of that tendency and can be helped to develop greater self-confidence. And and importantly, the distress and dysfunction caused by shyness is usually fairly minimal. So shy children can still be very successful at school, develop meaningful friendships, and pursue their interests despite their shyness. It even has its advantages. So shyness can be associated with positive behaviours, including conscientiousness. So shy children often do quite well at school and other activities, such as music and kind of other creative activities. Shy children are generally quite cooperative, so just nice for teachers and rarely get into trouble at school. They tend to be good listeners and are often easygoing, thoughtful and kind. But some parents do express concern about their children, about their children's shyness, particularly if it's quite marked. And so, you know, if we're approached for advice about how to help children with significant shyness, there are some things parents can do. So parental attitudes and behaviour are really important. Like with a lot of things in, in mental health, labelling can be an issue. So, so it's good to counsel parents not to label their children as shy, because children tend to live up to the labels other people give to them. The other classic one being, the naughty child who then lives up to that sort of label given to them. Encourage parents not to criticize or mock their child if they're shy, even if it's sort of with the best of intentions. Try to be as supportive, empathic and understanding as possible. Encourage your child to talk about the reasons for their shyness and what they're afraid of. So putting your fears into words and talking it through often reduces anxiety and helps create problem-solving opportunities. Parents, so unsurprisingly, shy children or parents of shy children have often experienced shyness in their own lives and their own childhood. So telling a child about times in your life you felt shy and how you overcame it can be quite helpful and helps normalize the experience for children who might feel embarrassed about their shyness. And, as much as possible, try to model confident behaviour and be outgoing yourself, recognising that that's not always easy for people, but just to do your best. So sharing some more strategies parents can use is sharing coping strategies that they've found helpful over the years for overcoming shyness. Talking, I think, making explicit some of the advantages of being shy, and framing it as, not necessarily such a bad thing. Praising your child when they do show outgoing behaviour or handle an unfamiliar situation with confidence. Do some goal setting with your child, aiming for small incremental steps. So even just saying hello to a new child or someone they don't know well might be quite a big step for some children. Really giving your child the opportunity to experience different things, visiting new locations, taking up new sports or hobbies, being in situations where they're likely to meet new people and make potential new friendships is very helpful. And most children do have areas of strength, so really encouraging them to develop that and praise them for the skills they've mastered. That is really good for their self-esteem and helpful in overcoming shyness. Where it's really relevant to mental health and our talk tonight is that shyness, as I said, is kind of on a spectrum with social anxiety disorder and predisposes to social anxiety. And there are a number of risk factors that predict who might progress from just being your average shy young person to actually to developing a social anxiety disorder. And that's things like genetics. Some people just have a stronger genetic loading for anxiety than others. Personality factors, particularly perfectionism, can be an issue. If excessive avoidance of problem or of social situations or anxiety-provoking situations becomes a pattern, then that can reinforce things. Family dysfunction and family and sort of conflict in family relationships can be a risk factor for anxiety disorders. Lack of opportunities for social interaction increases the risk, which is why it's important to give kids plenty of opportunity to try new things and meet new people. Harsh criticism from others, particularly parents, teachers, grandparents, other adults can be quite unhelpful. And some children have quite a strong fear of failure, which can really get them into a bit of a vicious cycle of avoidance and then kind of escalating anxiety. So that vicious cycle looks a bit like this. So you have a child who behaves in a shy fashion in a social situation, then they later berate themselves or are criticised by others for being shy. Fear that others have noticed the shy behaviour and judge them negatively for it. And then that self-reproach makes them more self-conscious and inhibited, increasing the likelihood of further shy behaviour. And so as time goes on, self-esteem and confidence are eroded, and that's potentially the pathway into social anxiety disorder. So as I was saying, social anxiety shares many features with shyness, but the main difference being the degree of anxiety and emotional distress, behavioural disturbance and impairment of functioning. And unlike shyness, social anxiety is associated with, poorer mental health. So a greater risk of other mental illness, including depression, substance abuse, self-harm and suicidal thinking and behaviour. So here are the DSM-5 criteria for social anxiety disorder, which was previously also known as social phobia. I won't go through anything because it's fairly lengthy, as the DSM tends to be, but just picking out the key points. So there's a marked fear or anxiety about one or more social situations in which the individual is exposed to scrutiny by others. So the key thing there is an intense fear. It's really an intense fear about what other people will think of the child. And it's also important to note that in children, the anxiety must occur in peer settings, not just during interactions with adults. So because of course there are a lot of children who are shy or wary around adults. That's not abnormal, but it's in peer settings where the dysfunction occurs. There's a real fear of doing something that will be humiliating or embarrassing for the person, and the feared outcome really is social rejection. In younger children, they may not express their distress in terms of feeling anxious or fearful. There might be much more behavioural symptoms, so crying, tantrums, freezing up, clinging, going quiet in social situations. So I think they're the key points there. So the fear, anxiety, or avoidance is persistent. So and to really meet the diagnostic criteria, need to be present for 6 months or more. There are a few sort of exclusion criteria, so it can't be attributable to other factors such as substance abuse, another mental disorder that affects social functioning, such as autism spectrum disorder. And the other one to mention is some people experience social anxiety in performance situations only. So that's particularly public speaking or even exams, things like that. So so there's a sort of performance only subtype of social anxiety worth keeping in mind. So really the key points there are social anxiety disorder involves excessive anxiety in social situations with an intense fear that others will judge the person negatively for their appearance, behaviour, or other reasons, and it will result in social rejection and or humiliation. The fear is irrational or out of proportion to the situation, and it's severe enough to cause significant emotional distress and functional impairment. So excessive avoidance of social events, reluctance, inability to do performative tasks in public, so including things like eating, and of course school refusal is a big one. So it's interesting just to note that different anxiety disorders peak at different developmental stages, corresponding with the important developmental tasks a child is working on at that stage of their life. So, for example, separation anxiety and specific phobias are the sorts of things that arise in quite young children. So, with that developmental model in mind, you would expect that social anxiety disorder might emerge in early adolescence, which is a time where children are starting to focus much more on peer relationships as really the central part of their life. For social anxiety and for anxiety disorders in general, comorbidity is very common, and I mean so common to almost be the norm, that if you have one anxiety disorder, you're quite likely to have another. So particularly generalized anxiety disorder and panic and agoraphobia often go along with social anxiety disorder. The comorbidity with major depression is also elevated, but to a lesser extent. And it's always, as always with anxiety in children, it's important to look for kind of indirect signs and symptoms. So somatization, school refusal, and so forth can often be signs of anxiety, even if the child's not verbalizing that they're feeling anxious. So the key difficulty for people with social anxiety is distorted thinking and self-beliefs and self-assessment. So contrary to their beliefs about themselves, children with social anxiety are actually generally likable and popular, which has been shown in various studies, including from Macquarie University. But sadly, for these children, they have a distorted perception of how others see them and imagine themselves to be unlikable in a way that makes them fearful of being shunned and disliked. In reality, the majority of children with social anxiety are more likely to be perceived positively than negatively by their peers, and which makes sense if you think about it, because socially anxious children are often really quite emotionally sort of sensitive to others' feelings, quite caring and eager to please, which, in a lot of ways are quite desirable characteristics. And so discussing the positive aspects of social anxiety, shyness and social anxiety can be therapeutic. And when you do that, you may want to reframe those as positive attributes. So, you might tell a child that, acknowledge a child is, thoughtful, gentle, a good listener, other positive qualities like that. So coming to treatment, so really the first line treatment for social anxiety is psychotherapy. Our overall goals in treatment are to relieve excessive anxiety, challenge and correct distorted thinking, and increase self-esteem through exposure to new people and situations, along with mastery of new skills, which include social skills. And one concept that's really critical to child mental health generally is that if a child's developmental trajectory is being disrupted by illness, so they're not doing the things that they should be doing, going to school, making friends, developing their social skills, then getting that child back onto their developmental trajectory as soon as possible is really important for reducing future morbidity. So, like I said, in most cases, psychological treatment really is the first line treatment for any childhood anxiety disorder, including social anxiety. There are many evidence-based modalities available. So the specific modality doesn't matter so much as making sure there is a theoretical framework underlying the psychological work that's being done with the child. Cognitive behavioural therapy has the most extensive evidence base, so and is often the preferred treatment for that reason, just because it's been around the longest and it's been the most studied. And the key concepts, as you're probably aware, in CBT are challenging distorted thinking, along with so that's the cognitive part, and then the behavioural part, which is graded exposure to anxiety-provoking situations. And the way you talk about that with children, depending on their age, is you can call challenging distorted thinking detective thinking, looking for thoughts that may or may not be realistic and what might be a more balanced way of thinking about the situation. And then with exposure, you can talk about taking a stepladder approach to problems, so slowly working your way up the sort of hierarchy of difficulty of tasks. And it's really critical that parents be involved in treatment. So parental involvement in psychological and pharmacological treatment, but psychological treatment really increases the efficacy of psychotherapy. And it doesn't have to be, obviously, it doesn't have to be attending every session, but it might. But as long as the parent is aware of the type of approach being taken, how to support the child to implement skills and strategies at home, it really helps reinforce what happens in the psychotherapy session. So what do you do if psychotherapy isn't enough. So look, if symptoms are not improving after a reasonable trial of psychotherapy, and sort of general consensus is, around 6 sessions of a structured therapy like CBT, you would hope to see some shift, obviously not a cure, but you would want to see some shift in a positive direction in symptoms. If there's just no improvement at all, that's when you would consider medication. SSRIs are the treatment of choice. Any SSRI is appropriate, with the exception of paroxetine, which can cause agitation in children and adolescents. Fluoxetine has the best evidence base for this age group. And its other advantage is because it has such a long half-life, you have a much lower risk of adverse effects if you miss a dose, which you can imagine in teenagers is not uncommon. Other antidepressants are used, but not recommended in primary care. Child psychiatrists might use SNRIs if SSRIs have not been effective, but then you're really getting into kind of more treatment-resistant kind of scenarios. Benzodiazepines do have a role in the short term, just in terms of crisis containment, but are not a long-term treatment option. And always with children, be aware of the risk of paradoxical reactions. So children who can become sort of quite disinhibited, irritable and aggressive with benzos. A way to reduce the risk of that is to use more of the short to medium duration benzos. And my personal preference is lorazepam. Diazepam, I find, because of its longer duration of action, has a higher risk of creating a paradoxical reaction. So the short to medium acting agents, I think, are better. And actually, it is worth remembering that if anxiety is occurring in performance situations only, and this is really thinking about, your year 11 and 12 students who are coping pretty well, but then experiencing very high levels of anxiety around exams and HSC and things like that, consider short-term treatment with the beta blocker, and typically you would use propranolol dose between 10 to 40 milligrams. And for some kids, that's all they need around exam time, and then at other times they do okay. The treatment outcomes for social anxiety are generally good, which is nice to be able to say. So most childhood anxiety disorders actually don't persist into adulthood. That's anxiety disorders. Having an anxious temperament or anxious personality often does persist, but people learn how to cope with that, and it has much less of a negative impact on their functioning. But conversely, most adults with a mood or anxiety disorder, have experienced childhood anxiety to a greater or lesser extent. So the way I would think about it is that, childhood anxiety is a potential risk factor for future anxiety and depression. But for most people, the message is an optimistic one. The majority of children do grow out of anxiety disorders. Right, I might try and race through this a little bit so we've got time for some discussion at the end. All right, cyberbullying. So, sadly, becoming quite a significant problem. what is it? So it's fairly broadly defined, actually. So the use of electronic communication to bully a person, typically by sending messages of an intimidating, insulting, or threatening nature. And that can be through many different mediums. It can be online, it can be via mobile phone. And there are some gender trends in cyberbullying which are not dissimilar to shall we call it traditional bullying. So for girls, often behaviours are around spreading rumours, sharing secrets, posting and sending messages and pictures making fun of or excluding people. With boys, often messages of a sexual nature or sexual harassment, often of girls, but may also include threats to fight or hurt others, which is sort of more so bullying directed towards other boys. And that includes, so some further examples. One worth mentioning is impersonating another person in order to make them look bad. That's surprisingly comes up surprisingly often, alongside the other more sort of typical behaviours. The other one, I guess, worth just mentioning in passing is so posting inappropriate or unflattering pictures of others, which might be sort of maybe fairly innocuous in nature. However, it does also include sharing sexually explicit images that may have initially been shared consensually through sexting, and of course that's it recently been made a criminal offence. So there is a role for there actually is a role for involving the legal system in those sorts of cases. Just thinking a little bit about differences kind of now and then. So with direct bullying, direct bullying would usually involve physical contact, so hitting, punching or shoving someone in a contained location, generally a school playground or something like that. But there would be quite a limited audience and the responsible party is easily identified. The reason cyberbullying, I think, is so pernicious is that it can occur anytime or place. So, phones or laptops are really ubiquitous with kind of, we'll call it traditional bullying. Children at least knew at the end of the day they'd get a break from bullying once they'd gotten home. But really with cyberbullying, there's no place to hide. It's really, potentially 24-hour a day, harassment. It's often to a much larger audience online. And also the bully can either remain anonymous or even impersonate another person. The other thing that I think is a real challenge for young people today that a lot of us growing up didn't have to deal with is just the ubiquity of mobile phones with photo and video recording ability, which really poses a unique threat to privacy. I think children are often aware of this, but it's worth reinforcing with them that once digital images are shared, then they can very rapidly move beyond your control, and once shared online, become almost impossible to erase. So just very briefly, with the effects of cyberbullying, people feel more vulnerable. It can contribute to depression and suicidality, anxiety and poor self-esteem. Often other symptoms, including psychosomatic complaints and insomnia, can result. The feelings of feelings of kind of shame and humiliation are what can be really most damaging. So I think the consensus generally, I think, is that cyberbullying, can be even more damaging than direct bullying, even direct physical bullying. Again, worth noting in passing that bullies often target people who are already vulnerable. Cyberbullying occurs generally outside of school and after hours, but it often begins with incidents at school. And it's at school where the impact is often first evident. So a child may start avoiding school. They may start to have kind of unexplained deterioration in their academic performance, impaired concentration, or talk about feeling unsafe in the school environment. Just to give some statistics and show the extent of this issue. So in some surveys, 43% of children have reported being bullied online at least once, and 25% have experienced it multiple times. The most common medium is mobile phone, which makes sense. It's the most kind of ubiquitous and accessible form of social media communication. 80% of young people think bullying online is easier to get away with than in person. Concerningly, only 10% of young people tell a parent or another trusted adult that the cyberbullying is happening. Girls are twice as likely as boys to be both victims and perpetrators of cyberbullying. And some of the comments can be really nasty. So it's quite common, sadly, very common to see comments like, nobody likes you, why aren't you dead, you should go kill yourself. Really quite cruel. I think the anonymity of the online environment really amplifies the cruelty of what some people are willing to say. There is a correlation between cyberbullying and suicide. Interestingly, in victims, as you would expect, but also in perpetrators, which I think reflects the fact that people who become bullies often have their own mental health struggles. Obviously, most victims of cyberbullying do not attempt suicide, but the ones that do usually have a comorbid psychiatric illness, and that might pre-exist the bullying, or it might be a consequence of the bullying. So I think it's a good practice, given how common cyberbullying is and how rarely it's spontaneously reported to adults. I think any young person sort of presenting with mental distress, it's worth asking them about bullying or cyberbullying, and then if that's present, do a standard psychiatric risk assessment kind of where appropriate. I might rush through the last few slides because I think we're getting short on time. So a lot of children are ambivalent about reporting cyberbullying and unwilling to come forward. Partly that's due to a number of reasons. One is fear of losing access to their phone or their iPad if they do tell adults, fears of retaliation, feeling that adults can't do anything to stop it or make the situation worse, worries about not being believed or that the situation will be trivialized. And similarly, reasons for not reporting cyberbullying at school is, well, they may not know who the perpetrator is, if it's occurring outside of school, they might be unsure what relevance it has to being reported at school. However, schools often can offer support and intervention, particularly when the perpetrator and victim are at the same school. So interventions that parents and children can implement are, sometimes just the common sense, simple solutions are the best. So blocking the sender, just deciding to ignore the messages. For children, I think, alerting an adult to what's happening. Sometimes asking the bully to stop is enough, but that requires quite significant assertiveness on the part of the child. Changing account details or email addresses. In more serious cases, keeping evidence of the cyberbullying just in case some sort of disciplinary action is required, either through the education system or, if it's really serious, through the legal system. And just remembering that abuse can be reported to social media administrators, and in very serious cases can be reported to the police, who who do have the ability to identify perpetrators via their internet service provider. So I might just say a couple of things about this. So just to say, it's very hard to supervise children on social media all the time. Well, impossible. So education really is the more effective approach. So really talking to your children about their online activities, and like taking an interest in their online activities and making it something that can be openly communicated about is really helpful. Educating children that cyberbullying, is not okay, and the adults are there to help them if needed. Schools can often help find appropriate solutions to cyberbullying, particularly when students are at the same school. And one thing we can do as parents is model appropriate behaviour by by using technology in an open, neutral part of the home. So not in the bedroom, the dining room or the living room. And something I know which is hard for a lot of us, but I think sets a good example for children, turning off devices at night. And I do have a case study, but I think we're running short of time, so I might skip over that. And
thanks very much, Peter. That was really informative. And I don't know, Lydia, are you happy for questions to go ahead, or did you want?
There's one question, yes, and we're happy to proceed quickly. Okay. Thank you. Yeah.
So Pete, just to clarify, if the DSM says substances like medications can cause anxiety, assuming that medication can't be stopped, how is treatment different? i.e. are the usual treatments less effective in cases like that?
It depends what it is. So I guess in children, you may have a situation, for example, in ADHD where a child's taking stimulant medication and has a degree of anxiety as a as a side effect of that, unfortunately. But because they've had a good response to treatment, you decide, you know, the best thing is to continue the treatment. Look, in that case, the standard treatments are still helpful. They're probably slightly less effective than in the absence of, you know, other medications that might be exacerbating anxiety, but they're still worth trying and they can make a big difference. So, so I would say, you know, if it's possible to adjust or change the medication contributing to the anxiety, then obviously you go ahead and do that. Sometimes you might not have that option, in which case psychological treatment and SSRIs can still be quite helpful.
And just quickly, do you think GPs can be starting SSRIs in, you know, adolescents, those under 16, or should they be referring on to a psychiatrist? And following on from that, if SSRIs are contraindicated, which sometimes happens, what would you recommend?
So I know, well, look, people have different level, you know, I guess different levels of confidence in, you know, with child and adolescent mental health. My sort of rule of thumb would be, if you know, 16 and over, which is, you know, your sort of, you know, year 11 and 12 kids, I think you can prescribe SSRIs with with a reasonably high degree of confidence. I think for younger, if children are younger than that, you may want to seek specialist input, but I, you know, I mean, this is a personal, this is not part of a therapeutic guideline. This is my personal opinion, but I think, you know, 16 and over, I think you can prescribe fairly confidently, and I think younger than that, you might want to get specialist input.
Okay, lovely. All right. I think we'll leave the questions there because we're at time, but thank you very much, Peter, for your part of the talk, and we might move on to our next speaker now.
Thanks for having me.
So our next speaker...
I have to turn my screen on.
Thanks, Pete. So our next speaker is Shay Gilbert, who works at Headspace at Miranda, and he's the mental health brief interventions and groups clinician. Shay trained in counselling, psychology and social work and has 14 years of experience in mental health. Shay works with educating and facilitating in both groups and students. And Shay believes a balance of working on goals and keeping in touch with what gives people joy, and the power of the client, and working with a relational focus. So looking forward to your contributions. Thanks, Shay.
Thank you. Am I being heard okay?
Yes, thank you.
I'll share my screen in a moment. I just would like to firstly, I know we've done a welcome to country, but I would also like to pay respect to any participant or anybody who is in attendance who has had any current or previous lived experience of any mental health issues. And I would like to acknowledge those experiences and validate that as part of people's journey. Okay, I'll share my screen. Just let me know if this works. How's that?
That looks good, thank you.
Okay. I have to say that going on from the previous discussion that you gave, Peter, I have found as a clinician that works both with individuals and groups, many young people withhold discussing anything around their technology as something that people hold quite dear to them, and they quite have to talk about most things in their lives except for their social media or their kind of technology. And when inquiring about bullying, a lot of people say it's not part of their lives, they're not involved in it, they haven't experienced it, and they don't do it to others. So that's it's quite an interesting barrier that I'm experiencing on a constant basis. So what you see there first is this first slide talks about two groups that we are running at Headspace. I guess we're plugging it at the moment. The first one is Riding the Wave, which is a distress tolerance and emotion regulation group that we are running on a continuous basis with two cohorts. One is from 12 to 15 or 16 years old, and the other one's from 16 to 25. These groups have a mindfulness component that young people are quite engaged in because it's using skills that bring people back into the here and now and present in their moment, that negate the traditional mindfulness component that people talk about when it comes to breathing techniques and closing your eyes, which a lot of people who have disclosed if they're experiencing trauma, they don't like to close their eyes in a group setting or around other people. It's quite uncomfortable and unnerving. So the traditional sense of the DBT that when people ask to do mindfulness in the traditional sense, it's become quite unnerving for young people. So we're trying to adapt it to something that young people feel more comfortable in doing, more engaging and more present in the here and now, hand-eye coordinating activities. The second group is They Just Don't Get Me. They Just Don't Get Me is a relational group which focuses on building healthy relationships in family, intimate relationships, and interpersonal friendships. This group works on communication skills, assertiveness skills, self-care, boundary setting, and different techniques on how to apologize and how to build and form healthy relationships. So there are two groups that we are running on a continuous basis, including what we're also going to be piloting trauma-focused yoga, as well as stress tolerance groups. And later in the year, we're hoping to pilot a Dungeons and Dragons groups, that is, has a clinical focus on building connections with other people, reducing anxiety, depression, building connections, and social networking for young people who might be isolated, especially coming from COVID. So just presenting a bit of a case study on how we are working with young people. So Kevin, obviously not his real name, presented to us with issues around anxiety and depression due to bullying in the school, one of those cases. He struggled socially due to splits in his circles. He was suspended from school. He had poor sleep. And I know this is quite a powerful word, and I apologize about this word, but he was noted in the triage as threatening his family with suicide and self-harm. There was some minor instances, but very minor risk associated with that. So the assessments that we undertook with Kevin included the intake and triage, which focuses on, which is a primary focus on risk, family history, background, and previous engagement with services. We obviously have a SOFIS, which is people's levels of functioning. We have a K10, a life tracker, and our HEADS, if people are not familiar with it, has a holistic assessment focusing on potential psychosis, depression, anxiety, work and school, sexuality and relationships, home life and environment, and a few others. But there's 10 domains that we then put into a case formulation, which leads into our brief interventions. And furthermore, can lead into Medicare benefit schemes and so on, or private practice. Interventions used with Kevin. Actually, Kevin is somebody I actually personally worked with. So interventions used with Kevin was ACT therapy, interpersonal therapy, narrative therapy, and DBT. Kevin found it, as much as the way I personally found it quite confronting to see visually his situation, his mind mapping, his experiences and his emotions mapped out on whiteboards. Generally, each week we took photographs of the whiteboards, and there was reflections that happened, and further works happened each week. The result of working with Kevin from these interventions assessments following the presentation was he gained hope. He established and sustained connections that were healthy and sustainable for him. He had a greater involvement in school than he had before due to his depression and his suspension. But his involvement in school before was quite pressured around his academic results and what he needed to achieve. He had enrolled in far more units than he really needed to. But afterwards, he decided to, change things, and he got some better sleep, decided to reduce his academic pressure. He decided that more of a life balance was better for him, because part of our focus at Headspace is to look at what makes people feel happy, what makes people feel comfortable, where do people like to go, what do people like to do, what creates a safe, happy, and comfortable environment for a young person. So that becomes part of our approach, along with what is it that they like about themselves, what gives them hope, what are they proud of, what are their skills and attributes, and what is it they like about their personalities. So these explorations not only put a focus on what is it that works for them, because a lot of people come into Headspace or to come in to see mental health treatment focusing on what's wrong with them, what they need to fix, coming in with the feeling that they are broken and they don't have hope. So one of the first things we like to do is to work with the hope, the connections, the pride in oneself, what they like about themselves and what makes them happy. To bring about a balanced approach, because it's not only about what to fix, but what to appreciate about the self. So therefore, Kevin created better relationships with his family, his friends, and he created a more sustainable life. That was all achieved within 7 sessions, 6 or 7 sessions. It was challenging to engage at the start because there was a number of sessions where they didn't turn up or there's difficulty in school, but after establishing some consistency, it led to a real wonderful outcome. So that's just so what do we do at Headspace? We have 4 main components. So the physical health, we have a GP, we have a dietitian, dentist that come in periodically. The dentists come in. We have a GP who's actually here 2 days a week, actually working full-time across both sites, 2.5 days here and 2.5 days at Hurstville. We have a periodic exercise physiologist, and we're looking at working with dietitians as well. We also have mental health, which I'll go into a bit further. We work with alcohol and other drugs, and vocational and educational support encouraging and facilitating people's employment and sustainability within education, both at school level and university level. This is an important slide. There's a couple of important messages on this one. So if people are unfamiliar with the streams that Headspace offers, especially when doing referrals to us, there's a number of different streams that we offer. One is the MBS, which needs a mental health treatment plan. It's required. That has 10 sessions plus 10 additional sessions which are covered due to COVID funding. These are reviewed by the GP that we have or the external GP after the 9th session, and then a letter to GP at session 18. The second one, which is quite similar but just a different approach, is the psychological support service, which also needs a mental health treatment plan. That is required, and a referral to the PHN. There's up to 18 sessions in the stream, and it's released in blocks by the PHN. So its review is needed after session 12 and 18. As mentioned previously, we have groups riding the wave, They Just Don't Get Me. We also have an anxiety group, which we have for 3 or 4 weeks between the Riding the Wave and They Just Don't Get Me groups. And we have the trauma yoga group starting in a few weeks. We also have a quite unique to Headspace. I'm familiar with Headspaces across New South Wales, and I've have colleagues working at a number of them. And I believe this is quite a unique position that we have a mental health clinician attending 4 schools within the Sutherland Shire and St. George district. So they're there to provide groups in school, which is not an early intervention. It's almost a prevention. So getting down below the early intervention, the earlier stage. So before people have reached out, so that there is groups there to talk about mental health in schools, provided by our early intervention, brief intervention service. And we also offer individual and group therapies in the school settings, which is fantastic to get in so early. Just important information for the attendees and for people to be aware of is the threshold for Headspace, from Headspace Miranda in particular and Hurstville, is that it's mild to moderate risk. So therefore, if a young person presents with suicide intervention or deliberate self-harm, we refer them to other services such as suicide prevention service, acute care, or CAMS. There's also some of the partnerships that we work with. Oh, I've noticed the time, sorry. I'll move a bit quicker. Some of the partners we work with are AOD alternating Mondays on site. We have Casper, who work with early intervention psychosis, Mondays and Tuesdays on site. We have family therapy on alternative Mondays on site. And we have CAMS as well, who offer online services. Important information for all our participants is that our current wait times are 1 week for triage, for our intake. It's 1 to 2 weeks for our first stage assessments, and it's around 2 to 3 weeks to see either MBS or PSS after the HEADS assessment. So it's a pretty rapid and low wait time. Just noticed that there's a question there. So how we do it, I'll just move through this a bit quicker. I'll extend that. Sorry. Let's get back on track. So how do we do this? How do we do the work we do? We try to relate to adolescents, make them feel comfortable to talk, removing power and dominance as much as possible. Strength-based and what makes people happy. Meeting a young person on their level, finding common ground. creating a safe space and a secure environment. And we work with the stresses and risk factors specific to the adolescents. We explored pressures through the HEADS assessment, as mentioned before. We work with biopsychosocial assessments, social media. That's how we engage with young people. Looking to build confidence. We have AOD work, so AOD specialist workers, psychoeducation. We work with a recovery model, strength focus, and mind mapping as demonstrated earlier. We work with academic concerns, liaising with schools, wellness coordinators, and linking with vocational support. We work with suicidal ideation, deliberate self-harm, safety planning. We increase support networks. We work from a strength-based self-worth. We work with reduction of shame, normalizing feelings, and harm minimization. So I might just conclude there because I've noticed the time. So, and I noticed that there's somebody due to speak soon.
Thanks very much, Shay. It's good to know the range of services that Headspace can offer. And I must say I am pleasantly surprised by your wait times. That is actually very short in comparison and for the services that you offer.
Yeah.
Just a couple of quick questions. The Riding the Wave and They Just Don't Get Me programs you talked about, do they need a referral into that, or can people self-refer?
They can self-refer, and to avoid any paperwork or referral forms for any of the participants listening, all that they need to do is to phone call or email Miranda directly or Hurstville directly. Okay. And we can do the intake process ourselves, and it's very quick, 5 to 10 minutes.
And there's a question here, so I don't know if you have an opinion on this, but if CBT's been tried with a an experienced psychologist, what would you consider the next most useful treatment? I know ACT, so acceptance and commitment therapy, is I guess increasingly used.
Professionally and personally, we have discussed as a team utilizing interpersonal therapy, as well as, well, I'm already a Rogerian, so I work with a relational focus, but we also use narrative therapy. So people are working with their own narrative and they're shifting to a new lens and a new perspective. So understanding their story in a better way. I never really found CBT to be the most helpful because it has so much tasks around it and so much forms and not forms, but it's very task orientated. People feel like it's homework.
Yeah.
So there's a feeling of resentment when CBT is put on the table. People kind of the reliability and validity that comes from young people engaging with CBT, it's quite questionable because of how they're just doing it to please the therapist. They're doing it to please the clinician. They're giving them the answers they want to hear. So I'm not really a fan of using CBT myself. So interpersonal relational therapy or interpersonal therapy, narrative therapy, and as I mentioned, ACT.
Yeah, they sound empowering, I guess, which is what we want for these adolescents.
Kylie, can I give a quick response to that as well?
Yes, of course.
So I was going to say, so look, in most studies of this, sorry, this is a very broad brush answer, and it's a bit more nuanced than this, but look, the broad brush answer is that most psychotherapeutic modalities show fairly similar efficacy for depression and anxiety. The important things are the quality of the therapeutic relationship, and some studies say up to 50% of the benefit of therapy comes from the therapeutic relationship between patient and therapist. So my answer to that question is I don't necessarily think the type of therapy. So if we're talking about anxiety and depression, generally speaking, I don't think the type of therapy is the most important factor. I think the quality of the relationship with the quality of the therapeutic relationship and the fit between patient and therapist is probably more important. But the other thing that's important is it doesn't necessarily matter what theoretical framework is being used, as long as there is a therapeutic framework being used. So find
a good therapist, and a good therapist will, create that therapeutic relationship and hopefully be flexible in finding the treatment modalities that suit them best.
Yeah, as I said, I think my approach is just to be quite relational. It's just about the relationship more than anything else.
Yeah, which I think is, I guess, is your point as well, Peter, with that therapeutic relationship.
Yeah.
Move on. Thank you very much, Shay. And I'm sure everyone here knows Dr. Martina Gleeson very well for her amazing and ongoing work with Health Pathways. And so I will let her speak to us regarding that. Thanks, Martina.
Thanks, Kylie, and hi, everybody. Hopefully you can see my screen, and those of you who are familiar with the talks that I give would be very familiar with the first 3 slides. So today what I'm doing is talking to you about the health pathways that are available that are related to tonight's topic. These are the QR codes to log in to the Sydney and the Southeastern Sydney Health Pathways sites if you've never used them before. And there's also the web addresses there for them. The login details are also listed, and you can actually use the same login to log in to Southeast Sydney or Sydney, because we're both partnered with the CESFN, so we share a lot of resources between us. And just a reminder, if you're needing to do a quick search, you're looking for something specific on health pathways, you can type in the word search in the search bar and then choose the relevant pathway. And then once you've expanded the whole pathway, you could press Control F, which is a word-based instruction, and type in the word that you're searching for, and all the results will be highlighted. So that can be helpful for any of the pathways that we're looking at. I just wanted to give you a list of some of the health pathways that are available between the 2 sites that are related to tonight's topic. And I know that we're Hazelhurst, and usually most of the GPs who participate are in the Sutherland Shire, but because this is a webinar, we could have people who are actually in the Sydney Health District as well. So, and sometimes it's helpful if you know that there isn't a pathway available in Southeastern Sydney, you can still use the Sydney pathways. So this is a list of some of the Sydney pathways related to adolescent mental health, and they keep going. And some of you will be familiar that health pathways have clinical pathways, where that describes the assessment and management of a particular condition, and then also helps you work out where to get help in the request section of the clinical pathways. And then we have separate request pathways which list all the resources. And so Sydney's got child and young adult mental health assessment, child and young adult mental health support, and online mental health therapy for adults. Southeastern Sydney has these clinical pathways: ADHD in children and young adults, and medication. We've got some good eating disorder pathways coming along. And I will keep going. A lot of these other pathways as well. And we've actually got a very extensive request section. So acute child and youth mental health assessment, non-acute child and youth mental health assessment. The difference between acute and non-acute in health pathways speak is acute takes you to emergency. A non-acute can be urgent but not emergency. So in health pathways, speak acute is usually needs to be assessed within 24 hours. But if it's something that urgent but doesn't need to go to emergency department, you go to the non-acute page. We've got child and adolescent eating disorders specialised assessment. And I'd like to tell you that there is currently an eating disorders service for child and youth in St George Hospital. So that's a new service, and I'd just like to point out that that's available. Child and youth mental health advice, if you need to call someone and get some advice, specific e-mental health resources for children and adolescents, counselling and psychology, and mental health helplines. I was asked to speak a little bit about mental health care plans, and I'm assuming that most people here are quite familiar with preparing mental health care plans. We've been doing it for a long time now. But if you're not familiar with it, there is actually a mental health care plan health pathway that describes how to prepare the plans. And you may or may not be aware that you don't have to use a specific template, but you are supposed to give the patient a copy of the mental health care plan, as well as pass it on to the person that you're referring to. So there are some templates that you might find useful if you're a little bit dissatisfied with the one you're using at the moment in your clinical practice software. So in the management section of our mental health care plan pathway, you'll find some links to some different pathways. And I've put links to those templates into this presentation, not because you can click on the links today, but because I'll send the PowerPoint to Lydia. And then if you're looking for alternatives for your templates, these ones that I've listed here are quite helpful. I'd like to point out in particular the GP mental health organisation down the bottom. They've got some new mental health care plan templates that have been developed in cooperation with the RACGP. Initially, when you look at them, they can be quite imposing. One of them is 24 pages long, which to me, it seems ridiculous. But if you did take the time to fill it in, it would be a very useful plan for anybody that's engaging with the young person. But they have two that I particularly like, and that's the Patient Wellbeing and Assessment and Recovery Plan Minimal Requirements, and the Patient Wellbeing Assessment and Recovery Plan using the SOAP way of organising your thoughts. One of the benefits of using those templates is they actually combine the mental health care plan with the referral and with the review. So if you complete all of the pages, you've got your referral already done. You don't need to prepare a separate document. And then when the patient comes back for a review, it's part of the document, so you can just fill that in at the review time. I was interested that Shay said that the review is done at before or after the 9th session with Headspace, because my understanding was always that there's a review after the first 6 sessions and then after the next 4 before you release the 10 sessions under COVID provisions. And I'll just give you a heads up that the extra 10 sessions under COVID provisions is meant to end on the 30th of June this year, unless they made a budget announcement last night that I missed, or unless they're planning on extending it, but they haven't yet announced it. So there would be quite a few people who'd be thinking they might get 20 sessions this year, but they might not if they haven't used them all up by the 30th of June. It's going to be it's interesting to see how that pans out. I'd just like to take a minute to share with you a live pathway, because I want to show you how to find the children and adolescent pathway, mental health pathways. So you'll see that if we're looking over here in the table of contents, we've got mental health and addiction, but that's mostly for adults. So if you look in the child and youth health, you'll find that there's a whole mental health section that has the those of you who've used health pathways will be familiar that the ones in black are pathways that we've localised, so they've got a white background and they're relevant to southeastern Sydney. The ones in grey will have a yellow background, and they will still have useful clinical information, but you'll see up the top this little banner, page not yet adapted, which means that we haven't localised it to our area. I really like to point out our quite extensive child and youth mental health requests page, because I'm really hoping that you'll find lots of options for you if you're seeking to find someone to help collaborate with you for the adolescent or child that you're seeing with mental health issues. So as I said, the acute child and mental health assessment is the emergency departments. Non-acute is more about how do you get a doctor or a senior clinician in the hospital system to help you with somebody who might need more than counselling, and also describes the different levels of mental health services with CESFN, who you can call for advice, what useful, clicked on the wrong one, what useful e-therapy modules there are. And there's also for children with parents with mental illness, and then the child and youth counselling support. And yes, Headspace is definitely listed there. So without sort of teaching you how to suck eggs, because I know you know how to write mental health care plans, I would encourage you to have a look at those templates and see if they might suit your needs better. And I would also encourage you to have a look at the health pathways that might help you with management of your patients. I just wanted to look at the anxiety one actually, because the mention of the HEADS assessment was there, and we've got quite a decent Dropbox with all of the domains of the HEADS assessment and some suggested questions that you might ask to do the HEADS assessment yourself, if you're feeling inclined to do that as you're assessing the child and trying to work out how you're going to approach helping them. So that's about all I've got to say about health pathways. I'm happy to answer any questions regarding them. I just would like to encourage you to have a look at them and hope they help. And the other thing, always, if there's something you find that's not correct, or something you'd like more information on, or if you find a broken link, if you click on the send feedback button, our team will get a notification, and we will act on any inaccuracy